into a 6-month training program across different industry and sector, whether it was masonry, construction, beauty and design, the culinary arts, across board. So we put you in that program for 6 months. You come out on the other side of it and kit you to be able to start off, whether it is your own business or whether it is joining someone in terms of getting a job or getting employment. So the 2Jedri program pulled out all the stops to make sure. And so far, 150,000 young people have gone through the program. 267 million shillings in terms of loans have been given out to ensure that people can be taken care of. And today, another cohort is taking in applications, and you also can be part of that. What you need to do to find out more information about it, go to the website, www.kcbgroup/foundation. CT,
yes.
You have a pep in your step and a giggle in your
gaggle.
A giggle in your wiggle. I was going to say gaggle, but okay. I reckon that it's because you have this great news and information about how we can all get a mortgage.
Yes, there's a little detail about how it is you can actually buy a house. Let's simplify it. Huh?
Yeah.
Mortgage, money you apply for.
Yes.
You qualify. You then have money to buy a house of your choice. Diamond Trust Bank are saying they have just the right plan for you. Meaning, they have mortgages, and they're saying, if you wish to find out more about it, you can either visit any of their branches, or you can actually send an email. The email is simple: mortgages@dtbafrica.com. But let's take a few steps back.
Okay.
This mortgage that I'm speaking of, what is it all about? One, Diamond Trust Bank is saying they'll offer you up to 105%. And you say, yes. Well, there are categories. If you happen to be employed, you stand a chance of being eligible. If you're self-employed, if you're in the diaspora, you can get up to 80%. And then they're saying, look, now let's put a little icing on this particular cake. The interest we'll charge you is 9% if it's a mortgage for 10 years, 9.75 if it's a mortgage for 25 years. And they're saying that in addition to this, we do not have any hidden charges, and neither do we have penalties if you pay in advance of the schedule that you have. Now, to verify what I've just said, let's go back to what I started off with. Go to any Diamond Trust Bank branch or send an email to mortgages@dtbafrica.com.
Wonderful. Wunderbar.
Yes.
And that's what we actually should be looking into as you start to have those conversations. And we never see where CT's diamonds will drop tomorrow. But even as we get into the final hour of this conversation this Monday, we're having a conversation about why, or rather, are Kenyan doctors ready to prescribe medical cannabis? Okay, Dr. David Okello is a healthcare professional, and he joins us this hour. He would have joined us with Mutua Mutuku, who unfortunately has had a bit of an accident this morning. So, I mean, our best wishes for him. But we will have this conversation either way, and we get into it. So, Dr. Okello, good morning, and Karibu Sana to the Situation Room.
Thank you.
Welcome. Before we get into some of these conversations, will probably take us to a high. Let us look at today's proverb. We'll give you a little bit of work as we get into it. CT has proverbs from the continent every week. He's in a different country, and he'll tell us what that proverb is, and then you can tell us how you would interpret that. Is that okay?
All right.
Fantastic.
Yes, our proverbs for the whole this week comes from the land of honest people, Burkina Faso. Okay? It's really a simple proverb. If you look for trouble, you will not miss it.
If you look for trouble, you'll not miss it.
Yeah, this is something like that, yes.
I would interpret it as if you're looking for something, you'll always find it. So whether it's trouble, whether it's something that is beneficial, but as long as you're looking for it, you'll find it.
Straight and to the point.
Yep. Sometimes it doesn't need any more depth than that.
Nope. That depth is deep enough. It
Yeah.
doesn't have to be like Tanganyika deep.
Yeah.
If you're looking for it, you will find it.
Just it.
All right. Dr. Okello, you're in the hot seat of the Situation Room, and this is a hot topic. But let's just start with a little bit in terms of definitions. Cannabis, when we hear it, we think, it's marijuana, people getting high, and then that's it. But over the years, the conversation has developed towards where we understand and we know that healthcare professionals around the globe have been using medical marijuana or cannabis for medical interventions, one of the big ones being pain management and things like that. How did we get into this place where we are today, where we have previously seen, cannabis, marijuana as a recreational drug, an illegal one in many parts, to the point whereby now we are saying it's very possible for you to use it for medical interventions? And can we use the two interchangeably when we say cannabis and when we say marijuana? Let's do that first intro as we get into it.
All right, thank you so much. Let me start with introductions. I'm Dr. David Okello. I am a researcher and innovator within the mental health space, where I innovate AI-based solutions for mental health care and alternative therapies. And I'm launching Healthy Minds Africa Collective Initiative to drive this conversation forward. So now on the conversation of cannabis, you want to call it...
Let me just pause, Daktari. Are you Daktari of medicine and syringes, or are you Daktari of reading and PhD?
Right now, just a general practitioner. However, I am working my way towards a PhD.
You are Daktari of Shindano?
Yes.
Okay,
right.
Very good. Now, please carry on. Yes. Yes.
So now, medical marijuana or cannabis. Now, the conversation began somewhere before 1920, when Kenya was fighting for independence. And cannabis or marijuana was commonly used among the freedom fighters. And the colonial power saw it as it made them rebellious towards the colonial rule, and they wanted to fight for independence. So during that time, it wasn't that cannabis was being smoked left, right, center, as we would want to see it today. It was a process that was being done by the herbalists or the spiritual team, which were in my mother tongue we call them Ajuaga. So they were the ones who were administering this. It wasn't for everybody. And public smoking is not African, even for cigarettes. Public smoking is not an African culture. So now, when it was criminalized in 1920, we dropped the conversation on cannabis and everything around it. Even research stopped. And the drug was portrayed as in a negative image. And the community decided to, over time, agree with the notion that the drug is bad. However, countries like Israel, where we have the father of cannabis, from the Hebrew University of Jerusalem, Dr. Raphael. He's the one who inspired the conversation on medical cannabis, and he was able to start that research out of curiosity. And we have seen published research that has shown that medical cannabis is able to provide treatments for certain conditions that today we are still struggling to manage. For example, Parkinson's disease and epilepsy, and even with HIV, it works for those who have the neuropathic pain. The neuropathic pain with HIV can be caused by HIV itself. It can also be caused by the ARVs that they're using. And
sorry, repeat that again. What can be caused by the ARVs again?
Neuropathic pain.
Correct.
Yeah.
Correct. Yes.
So now, as right now we have medications that we've been giving, but not all of them are working as we want.
Okay.
And if we are able to complement what we already have with this new research that can support, then I think there should be a direction that we need to go as a country.
which is this new research? Because what you have given us is a breakdown of, a general view of what should be done, what historically was done. But you do know that there's some myths that needs to be demystified around cannabis, that as a listener who's listening and watching today, they might want to hear you speak to those, including, of course, you've mentioned mental health, which a lot of people believe has a direct link to the uptake of cannabis. Is it a matter of the uptake, the amount you take? How many myths can you demystify for us just at the beginning of this conversation in relation to cannabis?
Okay. Now, with regards to research, first of all, we must acknowledge that almost all of them have been done in foreign countries. None has been done in Africa because of our policies. And we have seen the way it has been able to treat epilepsy and Parkinson's disease. And research has been published in public domain, and anybody who is interested can Google and find research on medical cannabis, and they're able to even
Google. There's a lot of information out here, and some people cannot really, verify their sources. Could be another misguiding line.
So now, with research on medical cannabis, now looking at the endocannabinoid system. This has been published by foreign universities, including the University of Jerusalem, but nothing from Kenya.
Okay.
And there is an endocannabinoid system that works for the cannabis. And this system is not currently being taught in medical school. And this system is a cell signaling system, and it is involved in communication between cells, and it is able to affect our appetite, pain, immune system, memory, emotions, and all that.
Hang on a minute, so that we can understand this. What did you call it?
Endocannabinoid system.
Endocannabinoid system exists where? Outside of the body, within the body, for those who are using it? What are we talking about here? Just so we can make it plain and understandable.
Okay. So the endocannabinoid system exists in the human body, including some other animals, and it is a system just like the nervous system, the cardiovascular system. So now this system has enzymes, it has receptors, just like any other system. And when we talk about enzymes and receptors, these are substances, proteins that are within the body that are able to enable molecules to pass from one side of the cell into the other. So now, every human being, whether they use cannabis, whether they do not use cannabis, they have the endocannabinoid system, and the endocannabinoid system has something called endocannabinoid, and this endocannabinoid is the body's marijuana. It is the body's cannabis. It is the body produces its own cannabis-like.
For what?
And this cannabis-like material, which is the endocannabinoid, it affects our emotions, it affects our mood. And
the stuff that we call like oxytocin, the same thing that is a mood enhancer.
Yeah,
that when I have a good feeling, oxytocin levels in my system rise. Is that what we're talking about?
No, so now we are talking about something like that. So now with the endocannabinoids, it will enable release of the dopamine and the serotonin. And these are the hormones that are always low when it comes to matters depression and other.
Let's go through this a little bit slow, okay? So what we are saying is that your system already, as a human being, you already have these substances, the enzymes in your system that are going to create a feeling, a high or a low. The dopamine, the serotonin, the oxytocin, all of this already exists. And what it does is that it mimics the same feeling that you get when you ingest cannabis. Is that what we're saying?
Yes.
Okay. So it exists in you already.
Yes, it exists in you already.
So now, those who would make a case against using medical marijuana would say to you, you already have this system. Why would you want to introduce something else?
Yeah, that would be a very interesting argument. But again, in the human body, you already have insulin. So why do you want to give a diabetic patient insulin?
No, but in a diabetic patient, there is the blockage of the production of it. there's a blockage of the production of it. So, and if you
I think it
have
depends on the
an
type of
insufficient
diabetes.
or an
sup-
Yeah.
insufficient supply,
of
Yeah.
it in the
that's why you
system.
need to
To
bring it
more.
in.
Yeah.
And in the same case also with depression, when you have the imbalances in the serotonin, in as much as it's already in the body, but you now have to give you a medication for it. So now the argument is, in as much as it already exists within the body, the moment we have a disorder, it is depleted. Now when it is not there, it has to be replaced, and that is where the medical aspect comes in.
Okay. How long does it stay in the body? For example, a diabetic patient who, needs an injection of insulin, maybe it's regular, what are we talking about? Every day, every other day, you need to then, make sure that you have it. So if somebody, and that's the thing, that we can't we can't divorce ourselves from the image. So what do you, for lack of, I'm just going to go colloquial here, do you smoke a joint when you are suffering from, depression? Is that what we're saying? Do that these are the conversations that people are asking. Are you going to smoke one every 24
what's the
hours?
dose?
What's the dose? What are we saying?
But then if I may chime into this discussion, remember there's off-the-counter medication,
Yeah.
which you can simply go and buy.
Yeah.
But
For diabetes,
are
right?
we then saying that you want marijuana to be at the point where it's an off-the-counter drug, or is it something that has to be prescribed?
Or is it for extreme special cases that must only be given by a medical practitioner?
Okay. So now, first of all, we must separate medical marijuana and recreational marijuana. With medical marijuana, you need evidence that it is working.
Okay.
And with medical marijuana, it has to be prescribed. And with medical marijuana, you do not have to smoke it. It has been processed into different, whether oil or a tablet or a syrup.
Okay.
And it comes with dosages. And in Kenya, I'm told that medical marijuana, these formulations already exist. However, it is only available to the who is who. And for those, the rest of the population, they probably get their supply illegally.
Okay.
And
Daktari, if we may pause, it is available, meaning the Pharmacy and Poisons Board have had a say in the availability in the country. Is that what we're saying?
yes.
So if they've had a say, then why then would it only be available to a few?
Okay. Right now, the regulations from the Pharmacy and Poisons Board are not so clear. That is why it's only available to a few. And that is why even the doctors and the other healthcare professionals do not want to touch on the subject, because hospitals will vilify you if you touch on the subject because of the regulations around it. However, the Pharmacy and Poisons Board allows that you can apply for a license and you are able to get medical marijuana into the country legally.
Let me ask the question. We are saying that there's a stigma attached to it.
Yes.
Okay. What is it that provides medical marijuana with direct competition?
Pardon?
What drugs or what types of drugs compete directly with marijuana for the same purpose, the same function that marijuana is supposed to actually achieve?
One would be the pain medications.
Okay, let me talk about, let me use a broad term. Synthetic medication. Would there not be a direct threat?
Yes. Now, for the synthetic medications for pain, we would say the coming in of medical cannabis would ruin their market, and you definitely will not expect the big pharma to support this at the moment, and that is why we have to tell the people that there is something that we need to look at. Because if you look at medical research history, for a condition like syphilis, we know that right now syphilis, we have stage 1 to stage 4. But how did we know that we have stage 1 to stage 4? It was through research. And how did this research occur? They denied the Africans medication. So when the Africans were suffering and dying, they were able to record. So now, when this thing is still new, why don't we able to change the
The
conversation?
Tuskegee experiment, it is quoted widely when you talk about research ethics. When it says Africans is right, but it was the black people in a place called... And that research took place over several decades, not weeks, decades. So he's right. They had syphilis, they were denied medication, so one could actually understand. And it's given as an example of what one ought not to do with research. And that's where the research ethics and the protection of human subjects and the need for this to be strictly adhered to, that's how it came into being, among other things that were considered. The reason why I brought in the discussion of competition is this. Marijuana and its usage has been in existence for as long as probably humanity has been in existence.
Yes.
Okay? And even in this same US of A, in the 1800s, leading up to the 1900s, it was used until a law was passed that then restricted to the point of almost prohibiting it. So, if you understand how laws are passed in many countries, you'd ask, who sponsored this law? Who is it who wanted? Because it was used, and there's documentation of the benefits that were derived from the use.
Yeah.
But immediately that came into being. We didn't have the term big pharma then. No, we didn't. What then replaced it? And what has continued to replace it? It is what now, it's now what we call big pharma. And it's not just marijuana. It has to do with herbalism. Diseases that were treated simply using herbs. Suddenly, there were all these questions about the efficacy of it.
Right.
And the evidence that is required for you to determine the contraindicatives, and languages that just puzzle you and just fill your mind. Now, we come to marijuana and the use of it. How do you get rid of the stigma? Because everything in this country that has to do with marijuana has to do with potheads. People who are either talking to themselves or picking up paper and talking to the paper.
Right.
Yes.
Or in a den full of smoke. And you're just,
yes. And
talking to the ancestors.
And talking about to people who nobody else sees and that sort of thing.
Hallucinations.
No. What do you mean? What do you mean?
I went extreme.
If you don't see the people, that's your problem.
So now changing the conversation around the stigma.
Yeah, it's around the stigma, yes.
Yeah, now changing that conversation requires that we look at the policies around medical marijuana.
Yes.
And when we're looking at the policies, we'll be looking at the doctors pushing this conversation forward.
Okay.
Yeah.
But isn't that the conversation that you do have, though? And it doesn't really matter, if you're talking about new interventions, because this is not a nascent conversation. It's been there for some time, right? But look at conversations that we can have comfortably today, whereby in an African context, you can have a conversation about HIV, which is hinged primarily on sex. You could never say the 3-letter word in the open. You would have to be under the bed with the curtains closed in the dead of night to even say the word sex out loud. But we can today, in medical spheres, have a conversation about HIV and its interventions. Now, when you talk about the removal of a stigma from something like CT talking about potheads in a den full of smoke somewhere, it's going to take some time for people to then start to resonate with, can we start to have the conversation that this cannabis can actually be used for pain management? Are those steps starting? Are we starting to have even the thought that we can, do something with it?
Okay. First of all, we must be able to break that stigma from among the doctors themselves.
Okay.
Because doctors are afraid of being vilified when they bring up the discussion on cannabis, because the cannabis drug has already been vilified among the community. However, Pharmacy and Poisons Board have been doing some policy regulations, and we'll be expecting them to bring something soon. However, as you're waiting to get there, we want to be able to work with patients who already understand what medical cannabis is and are already willing to work with medical cannabis. And based on their experiences, we will be able to gradually change the rest of society. Because that is a conversation we cannot spark up today and expect people to change the conversation today. That is definitely going to take us probably 3 to 5 years.
If I may ask, we have an institution called the Kenya Medical Research Institute. They even have a center for traditional medicine. Now, is this not the sort of conversation that maybe I should be asking them, but let me ask you. Is this not the sort of conversation that an institution like that would be best perhaps to assist in having, because it's what they do?
Actually, you're very right. That is what they do, and they should actually be doing it. But however, I've looked at what we have with research on medical cannabis in Kenya, and it is a new conversation that has started recently, and it is being driven by foreign organizations and foreign entities, and there are no Kenyans involved. So if the National Research Institute in Kenya can come up and take up this conversation, then begin offering research grants for it, and I believe we would be able to move faster. Because for the people, they would also want to read research that has been done and published in Kenya, other than just telling them everything foreign.
Okay. Well, it's a conversation about whether we're actually ready to have the conversation about medical cannabis in Kenya at this point. And we're having the conversation this morning with Dr. David Okello, and we'll come back after this break and continue with that. It's 27 minutes to 10.
This is Maisha Asubuhi, na kama ilivyo desturi naitwa Solomon Zuli. Moja inakuaga moja.
Yeah.
Mbili inakuaga ni twins.
Yes.
Lakini tatu kwa Kiswahili tunahitaji. Tunasema ni tatu sure.
Sugar boys and the cute boy, and ladies and gentlemen, I'm failing the one.
Mpigo tena zaidi finally bwana.
Finally.
Nimezama ndani ya stesheni nambari 1. Tuko mbele pamoja. Tatu shua zaidi. Nitamwambia ukipenda nitaji baba.
Karibu sana Nairobi, lakini mimi nitakupatia memo ya Nairobi. Watoto wazuri Nairobi. Lazima uwe makini.
Hapo archives hapo.
Ulipoingia tu. Hapo tutamuintroduce kwa kamba ndugu zangu.
Monday to Friday, each and every week, itakuwa ni tatu shua kama unavyotuona hapa. Sugar boy, Sugar Weasel, main man Rio, Solomon Jeffazuli. Hii ni
tatu shua zaidi.
Usipime.
Sawa, ndo nakuambianga masafara. Ukikunja huku unapatana sasa na masafara wa Urambaru, unaona? Hao ndio watu utakula ka snack hivi kabla tukakule hizi ni snacks. Sasa ni snacks, alafu ndio tukakule sasa nyama huko mbele.
Mali ni nyingi nyumbani. Kipi kikukimbisaka? Mali. Huyo msanii aliimba.
Wali mzee. Mimi sio mzee, mimi ni mheshimiwa Rwaka. Kwani mjuu ni MP wetu? Ni ulishaguliwa? Ni mimi niliingia. Ndio mimi nienda Narok. Niliingia na majority mimi. Si nominate. Hapana.
Doctors in Kenya ready to start prescribing cannabis or start to use it, medical cannabis. Has there been enough in terms of research? Has there been enough in terms of the participants of clinical trials, for example, to ensure that, number one, it's safe, it's accepted, there's no stigma, and that, it's readily available? Have the safeguards been set up? Has the Poisons Board been involved? These are all many questions that come into place before we ask, because at the end at the end is the doctors and the patients. There's this entire process that must take place before you put something out into the medical market that is safe, is accepted, and is not stigmatized.
All right, thank you so much. Now, in the UK, in Australia, this conversation on medical cannabis and research has been ongoing, and they already have formulations in form of tablets for it. And in Kenya, we do not have research on this subject, and that is something we need to start. However, with introducing the conversation to the doctors, whether they are ready to prescribe it or not. Right now, I wouldn't say they are ready to prescribe it because they do not know what it is and they do not know how it works. However, we need to start with the Pharmacy and Poisons Board so that we can set up regulations for it, so that even when we want to use it for research, the people must understand how it will be cultivated and who will be involved in the study, and what our objectives will be for the study. And once we have African Kenyan patients who are willing to work with Pharmacy and Poisons Board on this, then we will be able to have research material that we can publish and guide government in matters policy around medical marijuana. Because at the moment, Kenya has nothing to start with except for foreign-based research.
All right. Someone would ask, where is the stigma originating from? Is it the public? Is it the patient? Or is it the doctors? Just a simple question. Who's stigmatizing at this point?
Stigma originates from all the three. Stigma originates from government because of the policies that are first. Stigma originates from the community because they have been brainwashed over the years that this drug is bad and it is only associated with bad people.
Is it being brainwashed, or are some actually experiencing their kin involved in uptake of this, of course abusing it, and the result of it? Or is it merely just what you're saying, them being brainwashed, really?
I think it's just being brainwashed, really, because we have normalized smoking cigarettes, we have normalized drinking alcohol, yet we do have research published in Kenya and even outside Kenya that shows the dangers of these drugs, but somehow they've been accepted by society because of how they have been marketed over the years.
Right.
But for marijuana, it has always been placed in the negative image every time it is mentioned.
Speaking of this access being to the who knows who, yeah, because you do know that there are people who still abuse Piriton.
Yeah.
Just that tablet, and they just want to overdose and sleep like a sleeping pill. Other people who would abuse all these other medical, authorized medicine, and abuse it. And maybe that could be a concern, because if the public is not sensitized enough, and as much as doctors should be sensitized, they might still get a chance to use what should have been used for positive to abuse it for negative. Do you think this could be a possibility if not well checked?
I don't think that would be a concern, because already everybody is using the drug. Much of when I interview my patients.
Yes.
When you sit down with a patient and you ask, do you take cigarettes, do you smoke? They'll always tell you no. But when you speak with somebody in a language they understand, you begin to understand the crisis of the matter. And when marijuana has, over the years, been associated with everything bad, people have seen it as bad, and anybody who talks about it, I remember Professor Okello once initiated a conversation on it, and I think he was labeled crazy. However, if as a country we want to be able to lead in medical research in Africa, because that is something that much of Africa is not doing, because research is underfunded in Africa. But if as Kenya we can begin leading the conversation on medical cannabis and research around medical cannabis, then I think Kenya will be the go-to blueprint for Africa when it comes to matters medical.
So I think that research question then that you've talked about then is extremely important, especially when we talk about a mental health burden on the country that is equatable to a big malaria burden, a big HIV burden. we think of mental health in a lot of cases as, just, maybe a subsidiary to illness, but it is an illness, and it is hitting on quite a large number of the population. So in as much as we see research being done in the fields of malaria, of HIV, of cancer, for something that's gripping the nation so much, why don't we see as much research done into interventions for mental health, like this, for example?
Okay. We must first start by acknowledging that mental health has been sidelined in discussions in almost all countries over the years. And that is why mental health is where it is right now. And even for the people, when you mention mental health, they stigmatize it, because the public facilities for mental health, when you look at them, you just see a prison. The services are not welcoming. And now that stigma, then you now bring in an alternative therapy like medical marijuana, cannabis, that has also been stigmatized over the years. So we are bringing two stigmatized things at the same time to a community that is not aware of what is happening, and a community that is already addicted and suffering from drug abuse. And we cannot put medical cannabis aside, fearing drug abuse, because we already have abuse existing. And even for prescription drugs like the opioids like tramadol and morphine, they're already being abused even by patients and by doctors. However, that should not be the reason why we are stopping medical cannabis, because in as much as the opioids are being abused and the anesthesia is also being abused, we haven't stopped using them on patients. Yeah, but we should be able to make regulations around it and provide support to persons who are dealing with abuse, because abuse of a drug, that is now a mental health condition, and that needs to be treated as such.
But Gary, who's leading this conversation that seems to have stigmatized? I said it before and I'm repeating it. Because traditionally, forget the Europeans, the Chinese, here on this continent, even the community I come from, cannabis was used recreationally. There are instances where I have been told it was used medicinally. And the people who consumed it you had to be of a certain age, and it was for specific purposes. Meaning, that is what you call regulation. It was regulated. The abuse goes out of what we call regulation, and abuse is always there, but it was understood. The stigma did not exist, not really, because it was understood. It was the same with alcohol, consumed at a certain time, consumed within certain age brackets. Again, alcohol has never been stigmatized, but the stigmatization has crept in over time because of the abuse. Now, what I'm saying is this: a conversation such as this one, taking into account that the conversation of the stigma is fairly profound, must look at what it is that cannabis has already been used for, even before we started talking about medical cannabis. It isn't as though cannabis has not been used in medicines. It has. It's just that conversation isn't loud enough. So, if it has been used, and the drugs that it has been used in have been prescribed and have been used and have been found to be useful, it points to a simple fact that its use is actually not in doubt. So, what is it that is in doubt? Its safety, regulation, really. How? If things which are infinitely more potent, because if you look at what we now call opioids, the side effects that you get from some of these synthetic medication are far, far more adverse than you would get. And modern research is tending to tell you that cannabis would probably have the same sort of effect, the same effect that these opioids have. Again, the conversation I had before, who is it who produces opioids? Cannabis is addictive, but the degree to which opioids are addictive are God knows how many times more than cannabis. So again, You are talking about the promotion of something which is far more dangerous, far more adverse, and far more acceptable, and yet the dangers are clear, it is known. And you're talking about a product whose dangers are known, but cannot even compare with what has been accepted and what is even sold and what is even prescribed. Now, surely, is that not a lopsided conversation?
Definitely. We are being ostriches hiding our heads in the sand.
Yes.
And this is a conversation we need to start as Kenya, because the rest of Africa is not going to start it. So if we can start it as Kenya, so that we can have research published in Kenya, then that would be a good way to go. Because if you look at HIV and the ARVs, much of the research we relied on was from the foreign countries. And by the time we began research on HIV in Kenya, it had taken quite a while. And scientifically, the effect of drugs is not the same among the races. So
no, it is not.
Yeah. So if it works for a white man within a particular dosage, it will probably not work for an African within that dosage.
Or an Asian, for that matter.
Yeah. Exactly. So you'll probably have to raise it or lower it. Yeah. So if we cannot do research among ourselves and get to know the truth and move forward, then it is going to be hard for us. We will now have to be relying on other people's information, which might not work for us.
And Dr. I agree with you, because we saw what happened during COVID. There are people who expected that Africans would respond differently to that particular virus compared to how it happened in the European countries. But that aside, look at this. For somebody who really is interested in this conversation, in as far as the medical side is concerned, there are certain people who will need this cannabis more than other people. Chronic diseases, people who go through very severe pain. I just wanted to paint that picture for me, who are the first patients who we should move with speed for, all right, as a country, as a continent, that really need this solution to be reached very quickly. Because I'm sure as you're speaking, the who knows who are particularly using it on their patients who seemingly are getting more reprieve than others that we're speaking. Which patients are you looking at, according to the research you've interacted with?
So now, according to the research I've interacted with, we are looking at patients who have chronic, the non-communicable diseases, the chronic conditions. And in as much as today somebody who's listening might say they do not have a chronic condition, but we are all candidates for a chronic condition at one point in our lives, whether we are young or old, but at one point in our lives, we will depend on medication to stay alive. And when that time comes, you want to take medication that works for you and your pocket and has lesser side effects as compared to what already exists. And there was this patient in the UK, a child who had a rare form of epilepsy and was always convulsing. And when this patient was started on medical marijuana, the convulsions disappeared. The doctor that was attending to that patient said that in the waiting room, just waiting to see the patient already had 3 convulsions. And that is serious. They had been on every medication available and never worked. So when this patient was put on medical cannabis, within 24 hours, there were no convulsions and the patient was okay. And that patient stimulated the conversation on policy change for medical marijuana in the UK. So if we can learn from those and inspire conversation here in Kenya, so that persons who have chronic conditions and have been on one painkiller after another. You find somebody's bag, you think they have money, but it is just a packet of painkillers, but they are not working. So now if this person can be told that, now we have this drug, would you want to try it? And they say yes, if they consent and it works for them. Then they go out to the community and say, by the way, I tried this and it worked. Would that not be a good thing? And will that not be able to inspire change among the community on medical cannabis and what it is all about? Because the late MP who inspired this conversation on medical cannabis was suffering from cancer at the time.
Kibera?
Yeah. And that MP, I think he was probably able to access it. I'm not sure. But if he was suffering from cancer and was advocating for medical cannabis so that it's able to assist with the side effects of cancer and its treatment.
Yeah.
And if it's able to work, then I think we should be able to offer people better way of living, even when they are terminally ill.
Yeah.
There is no guarantee that the chemotherapy and radiotherapy will reverse your cancer at stage 3 or stage 4. Even if we took you for surgery, probably it will not. But what if we are able to help you manage that pain without putting you through a basket of medications? So if we are able to offer you medical marijuana that is able to make you live your life peacefully, even as you wait to demise, is that not a better position to place a patient than to pack them with unnecessary medications that we know are not working, but are just contributing to the side effects that they're already suffering
Are
from?
you saying
Indeed.
that someone should die happy?
Yeah, I believe in people dying happy, not people dying sad and in pain. Because when they die sad and in pain, that pain is transferred to the family who is also supporting you. And it becomes a very hard moment for most people. Yeah.
I imagine. I think that it's necessary to debunk this idea in the minds of people that what we're essentially saying is that the way you would go into, clinic and get an injection, or that you would go to a pharmacy and get over the counter, that there's no little smoking room where people are going to go to and get their dose of medical cannabis to sort out their issue. I think we need to separate the two for it to be clear in people's minds, because those questions keep coming. That are we encouraging people to go smoke? I mean, colloquialism again, but are we encouraging people to go and smoke a joint? You had said it before that we're talking about the presentation being different of the medication, but can you do that again just for understanding across board?
Yes. So now one thing we must understand is that when we are advocating for medical cannabis, we are not saying that people should be allowed to smoke left, right, center, because that is not African. And smoking itself is dangerous. And when we allow for medical cannabis, it allows for research into preparing formulations that are safe and even much more effective, and with the required dosages that are effective for the African community. So the joint, as it is, when you roll up a joint, you smoke it. One, you do not know the quantity of cannabis that is in that joint, and two, you're smoking it to get high and not smoking it because you have a condition that it is treating, then over time that will be a problem for you. It will create a problem for you.
Does it take us back to that conversation that your body already has some level of it, and if you're just but smoking it to increase it into your body, that's going to get to some extreme severe composition in your body? Does it? I'm trying to think like a doctor here because there's an amount you said that the body does produce.
Yes.
So those who smoke it when they don't really need it, it's just by being detrimental for them. Maybe you need to explain that to them, because I'm seeing a lot of conversation in the comment section as well.
Yeah. So now when you smoke it and you don't need it because your body already has it, and you do not have a disorder that is interfering with its production, then with those people, over time they will lose that sense, that happiness that they always have, and they will always be dependent on the drug for happiness.
So you become depressed again?
Yes, it will now get you depressed, and that will now stimulate the bipolar affective disorders for most people. Yes.
Thank you, Doc.
So, where would be the next step in this conversation in terms of what do you see happening next, where people are now involved in saying let's bring in alternative? It is an alternative, away from the traditional interventions that folks have used before. What would be the next step in this conversation?
Yeah, the next step in this conversation would be getting pharmacy and poisons board on the table, so that they are able to involve the people in formulating policies around research on medical marijuana. And they need to involve stakeholders. Right now, you need to register in the Pharmacy and Poisons Board website to get license. And it is only the pharmacists who are able to do that. The other cadres, in as much as they're the ones who are doing the prescription, they're not able to do that. So now if we are able to involve the other regulatory bodies, the medical council, the nursing council, the clinicians council, and we are able to formulate policies so that the healthcare workers can follow and we can begin collecting data on medical marijuana.
Do we have a legal...